Hello everyone, and welcome to another VMR session. This is Parisa, and we are so excited to host another Teaching Point recap session. We are having three amazing Academy members who have prepared cases from the last VMR for us. We are going to reflect on these cases together, and we are going to learn from them. If you have any questions from this presentation, please feel free to put them in the chat, and then we are going to address those questions at the end of each presentation. Our first case presenter is our dear friend Johan. Johan, please introduce yourself and feel free to share your screen.
All right. Hello, everyone. I'm Johan. I'm a proud TP Solver Academy member, and I have a really interesting case to share with you. I will share my screen. All right. All right. Can you see the case? Can you see my screen? All right. Perfect. So this was a case presented a few days ago by the Willis Neaton IM program. I had the chance to discuss that case with Dr. Ravi. It was an amazing case, so humbling. And I think it's really important to me to just take the chance to share it with you since I had the time to reflect about the case as well. So let's start. So let's start with the problem representation. Chief complaint, it's a 74 years old male presenting with around 25 pounds unintentional weight loss over 6 months. The key elements on the HPI were unexplained weight loss, fatigue, and progressive difficulty in daily activities. It's important to know the past medical history and the social history in this patient. I'm not spoiling you, but you will know why. So, non-Hodgkin lymphoma 22 years ago, prostate cancer, HIV, hypertension, and other cardiovascular disease things. Social history, chronic active smokers, 50 pack a years. So basically, the patient has weight loss, and regarding weight loss, you should have multiple, I'll say, oh my bad. You should have multiple mental buckets, but the first question you should ask yourself, is there inflammation or no? Well, let's start with no inflammation, right? First thing first, the patient has weight loss. So first question, is he actually like eating? Is he taking, is his like food intake sufficient? And here you have three main factors: access, desire, and discomfort. So access is just food insecurity. If your patient is in a situation of food insecurity, it might explain the weight loss. After that, you can think about desire, so depression, eating disorders. Third point will be discomfort, so think about dysphagia. Another bucket as well will be malabsorption, right? So if the intake is good, so why is he losing weight? So you also have to rule out SIBO, pancreatitis, and celiac disease. And you have other causes like medication, bupropion SNRIs, endocrine, diabetes, adrenals, and chronic organ diseases like cardiac cachexia, cirrhosis, chronic end-stage renal disease, for example, that can lead to weight loss as well. And if there is inflammation, meaning fever, increased ESR and CRP, increased WBCs, decrease hemoglobin or albumin, for example, now you can maybe think about cancer because of the inflammation, infection, and autoimmune condition. But to think about our patient, he has an history of non-Hodgkin lymphoma, which is an hematologic cancer, and also HIV, which is supposedly well controlled, right? So I would go back to the precedent slide. So he said that his weight loss is unintentional, and he self-presented regarding this weight loss. So maybe for now we should lean more toward inflammation, right? Especially with the past medical history and the HBI overall of the patient. So now let's go through the physical exam and the imaging findings. So overall, the vitals are normal, exam findings are normal. So if we pause here, it's hard to make any real progress because everything is normal, but you want to see the CBC, you want to see the like the infectious panel, for example, and you really want to go and dig for the infectious causes, and you're also thinking about cancer at the back of your mind. So maybe since the patient has non-Hodgkin lymphoma, if it's uh, restarting again, for example, and with a huge history of uh, tobacco abuse, he's prone to so many cancer as well. So at this point, especially with the labs that are almost normal, a part of the macrocytic anemia, we thought about doing a PET-CT, what they did at Willis Neaton. And what was important with it was the CT chest, where they saw cavitary lesion in the lung bases and non-calcified nodules. So let's reframe it again. The patient came with weight loss. We didn't really find any non-inflammatory causes. So we are thinking more about the inflammatory causes. And we have two buckets now, infectious or a malignant cause. For now, we lean more toward the malignant cause because we not more toward the infectious cause because of the result we have on the chest CT. But overall, let's review our approach at TP solvers of lung nodules. So when on a CT or X-ray you see a lung nodules, you should put them in three buckets. I mean, for me, I would make it even easier for you. Just think about infectious or non-infectious. It will be easy. Now the pattern on CTs, I mean, you can also see it like this, but I feel like it's just easier to see the infectious and non-infectious. So first, the infectious causes, virus, bacteria, mycobacteria, that can be disseminated as well and be hematogenous. And you have the miscellaneous, so sarcoidosis, pneumoconiosis, that has to merge with the whole HPL and the whole clinical picture as well. You also have like aspiration and hypersensitivity pneumonia, pneumonitis that has to merge with the clinical picture. But if we have to think about our patient, we have like non-calcifying, we have calcifying nodules and sort of granulomas, so we can rule out so many things already. So on our differential, we'll keep TB, we'll keep hematogenous malignancy, and for the rest, it's really unlikely, right? Because I mean, you won't present with 6 months weight loss and ACT like this if you have hypersensitivity pneumonitis, for example. So based on that, they decided to do a comprehensive infectious workup at your program, and it was completely negative. So they went ahead and they did a biopsy, and the final diagnosis was Langerhans cell histiocytosis. So just to come back to this schema, so if the infectious workup is completely negative, the only thing we will have less is the non-infectious causes, right? So regarding our patient, it can be hypersensitivity pneumonitis that has a completely different presentation. It can be aspiration either. It's not a solid tumor metastasis because, I mean, anyway, we have a PAN-CT, so we'll see it, you know. So the only thing you have to do now with the biopsy to see exactly what's happening. And the CT was so expressive and the cavities were so big, so it was pretty easy to do the biopsy. And luckily, they were able to diagnose the patient with Langerhans cell histiocytosis. So I'll just do a quick review of the condition that is not well known. And I have this schema from Mayo Clinic. So Langerhans cell histiocytosis is a rare condition that can has respiratory manifestation like we saw with our patient, endocrine manifestation as well with diabetes insipidus, for example. It can also affect the pituitary, so just be aware of that as well. It can affect the nervous system, the bones with osteolytic lesion, and also has the hematologic effect with a papular rash. So basically, Langerhans cell histiocytosis is a zebra, and when you don't see anything, think about it. If you have any of this manifestation, it will definitely help. So just to summarize the main pearls of that case, there is a strong smoking association between pulmonary Langerhans cell histiocytosis. I mean, there's a smoking association between this condition and the vision. And radiology clues are really important. So cavitary nodules, irregular cyst. You have very few conditions that can present like this. So you should also have Langerhans cell histiocytosis in your differential. And when you have infection versus um, um, pulmonary Langerhans cell histiocytosis, if you have a completely negative workup, you have to think about something else. If the infectious workup is negative, start thinking about non-infection causes as well, and avoid anchoring bias. So okay, we thought about malignancy, we talked about TB, but there are these zebra that still has to be considered. The gold standard for diagnosis is biopsy, and a big part of management in this type of cases is smoking cessation, and that's what they did, and it really helped the patient overall. So thank you for listening to this case. I really enjoyed discussing that case few days back, and I'm really happy to vulgarize that condition that is not well known, that is Langerhans cell histiocytosis, and hopefully it will be easily diagnosed in the future. Thank you.
It was an amazing summary, Johan. Thank you so much. I really love your discussion it was a really challenging case, and now you really summarize it really well. I really like the way you were incorporating inflammatory versus non-inflammatory weight loss, and I really love the way you were also including the lung nodule schema as well. Usually having the systematic review really helping us to guiding us through the branch point, and you really did it really well. Thank you so much. The next case presenter is our dear friend, Aya. Aya, please introduce yourself and feel free to share the screen.
Yeah, hi everyone. Welcome to our teaching point. So I'm A. I'm a medical graduate from VMR, now working at clinical research at WashU, and I will be applying neurology residency this year. So I'm so excited. Okay, so this is a case of 1.5 syndrome presented by me and discussed by Dr. Aaron Berkowitz and Valley on December 24, which is just Christmas Eve. And I will be doing teaching part again for this case. So this is a really fun and cute name, like 1.5 syndrome. So, so the problem representation is it's a 73 years old male. Can with sudden onset of double vision for 1 day. There was no past episode of double vision, and the double vision is on side to side, so it's horizontal diplopia and it's very constant. There is no fatigability or toothy or blurred vision, and there is no associated headache or periorbital pain, weakness, sensory symptoms, weight loss, or bowel bladder. And but he has a past history of hypertension and hyperlipidemia, and on antihypertensive, but just recently stopped statin. Okay. Oh. So how are we gonna approach double vision? So this is a schema from our dear clinical problem solvers. When the patient present with double vision, we have to first decide is that monocular or binocular. So we ask the patient to close one eye, and if the diplopia state persists in closing one eye, so the problem is from that eye, right? So it's mostly the eye problems. But if the double vision goes away when you close your eyes, it is due to the eye misalignment. So it's most probably due to the neurological problems. So we call it binocular diplopia. because the double visions appears only when you're using bull eye, because it's a misalignment. So we are doing a lot of like eye movements every day without even noticing. There are a lot of cortical inputs from the frontal IV, also from the occipital visual cortex, and then send signals to the midbrain and pons, where our final pathways to the extraocular eye muscles and nerve are. So they come down. Okay, so for the extraocular eye movements, we have mnemonic like LR6, SO4, and all other three. So lateral rectus is supplied by the 6 cranial nerve. SO4, superior oblique, is supplied by cranial nerve 4, and the others are supplied by cranial nerve 3. If you have the double visions, like mostly for the horizontal diplopia, it could be due to from anywhere, like starting from the midbrains and the cranial nerves, or the neuromuscular junction like myasthenia gravis, and the extraocular muscles like direct eye disease. Okay, so there is also one important thing to know about. It's the medial longitudinal fasciculus, which carry out the conjugate eye movement. So if you are looking to the left, your right frontal IV send a signal to the left parapontine reticular formation, and it sends signals to the 6 cranial nerve to the ipsilateral side, so that your left eye do AB detection, and the right eye do A detection, so that you look at the left and to the right also. So the medial longitudinal fasciculus send an input, got an input from the ciscranial nerve, and then go to the opposite side of that cranial nerve, so that you do A detection, and to the ciscranial nerve and do a detection. Okay, so back to our case. On neurological examinations, the other mental status, motor power, reflexes, plantar, sensory coordination, they are all normal. But cranial nerve, okay, so first thing, the double vision goes away with closing of either eye, so it's ocular misalignment. And on left lateral gaze, both eyes stays in the middle. They cannot, the left eye cannot do A detection, or the right eye cannot do A detection. And on the right lateral gaze, the left eye stays in the midline, but the right eye can do A detection with nystagmus. So where is the lesion? The other, okay, so the other cranial nerve, 5, 7, 8, 9, 10, 12, they are normal. Okay, so where is the lesions? So this is the an unaffected vision when you look to the right and when you look to the left. If it is just in the medial longitudinal fasciculus, you only cannot only the A detection is affected. So when you look, so here it's called internuclear ophthalmoplegia, where the medial longitudinal fasciculus is affected. So if you look on the right, it's okay. Okay, if you look in the left, the right eye cannot do A detection. And the other eye, it's on this is nystagmus. Like this eye is not coming to where he is calling, so he's like shouting, "Hey, can you come? Can you come?" So he has a nystagmus on the other side. But for the 1.5 syndrome, so the lesions are in the dorsal pons, so it affects the parapontine reticular formation. So the ipsilateral, it sends signal to the left, right 6 nerve, so the eye cannot do A detection, and the opposite A detection. And the same side A detection either. So when you look to the right, okay, so when you look to the left eye cannot do A detection and the A detection. So this is the left eye has 6 nerve palsy, and with medial longitudinal fasciculus, the right eye cannot do A detection. And to the right side, the nerve eye cannot do a detection due to that nerve palsy, but the other left eye head can do cannot do it can do a detection. Okay, so the MRI brain has more infarct in the left dorsal pons. Okay, so for the take-home message, if the patients come with diplopia, it is either monocular or binocular, so that we differentiate between the eye problems and the misalignment problems. Is it horizontal or vertical? And for the extraocular eye movement, we have the mnemonic, LR6, SO4, and all other trees. And for conjugate eye movement, to look at the left, the right frontal eye field sends signals to the left parapondyle reticular formation, so that the 6 cranial nerve to the 6 cranial nerve nuclei send signal to cranial nerve 6, so that the left lateral rectus walk, and then it sends signal to the opposite cranial nerve 3, so the right so the medial rectus walks for the eyes to a detect. For internuclear ophthalmoplegia, it's a medial longitudinal fascicular lesion. So it affects the ipsilateral cranial nerve 3, so the eyes cannot detect with the nystagmus on the opposite side. But for the 1.5 syndrome, it's lesion in the dorsal pons, so it affects all parapondyle reticular formation, so affecting both cranial nerve 6 and also the opposite cranial nerve 3, and the same medial longitudinal fasciculus and the same that nerve palsy. So the causes are mostly due to vesicular infarct, demyelination, or infection, and the rare causes could be trauma and tumor. Okay, so this is 1.5 syndrome. We have some fan calculations game here. So the 1.5 syndrome, and you can see the cranial nerve 7 goes near the cranial nerve 6. So sometimes the cranial nerve 7 are affected. So 1.5 plus 7, we call 8.5 syndrome. So there is also corticospinal tract here, and sometimes it affects the corticospinal tract, and the patient present with ipsilateral hemiparesis or weakness. So it's half of the body involved. So 8.5 plus half, we call it 9 syndrome. And then sometimes it has 5 cranial nerve, trigeminal nerve also involved. So 1.5 plus 7 plus 5, we call it 13.5 syndrome. And sometimes it has bilateral 7 nerve involved. So 7 plus 7 plus 1.5 is called 15.5. And sometimes it has cranial nerve 7 and 8 involved. So 1.5 plus 7 is plus 8 is called 16.5 syndrome. So yeah, I hope you all enjoyed the 1.5 syndrome case. Thank you all for your attention. This is my references, and I'm happy to answer any questions. Thank you.
It was amazing presentation. I learned so much, and thank you so much, absolutely, for sharing this fantastic case for us. It really, as you know yourself, it sparked many great discussion in the academy, and also it was a really master class on neuroanatomy and neuroophthalmology. We learned a lot. Thank you so much. If anyone has any question, please feel free to put it in the chat. Okay, if not, we will move on to our last case presenter, which is our dear friend Rahul. Please feel free to introduce. Oh, we don't have any question. Please feel free to introduce yourself and share your screen.
Hello everybody. Hello, hi. I'm Rahul. I'm one of the CP Solvers Academy member. First of all, this is the first time I'm doing the Teaching Points VMR. I'm absolutely thrilled and so happy to be here today and sharing some of the key points where Keaton presented the case on Still's disease on Christmas. And yeah, thank you so much and for the opportunity I had. And let me share my screen. Can you able to see my screen? Oh. So So I just wanna re-emphasize on the problem statement here. So he was a 30-year-old male, as an engineering student at Chicago, with no significant past medical history, and he went for a party with his friends. And after 2 days of the party, and for a few of his friends had developed some kind of gastroenteritis symptoms like nausea, vomiting, and which self-resolved later. But he's the guy who presented with persistent fevers, not only with that, with drenching night sweats and vomiting, nausea, and sore throat, where he was not able to tolerate a minimal amount of oral intake, which prompted him to go to the ER. And also on further evaluation, he also complained of left upper quadrant pain which is increasing on deep breathing. And when Reza and Sharmin was discussing about this aliquot, the two main concerning things here is fever with associated drenching night sweats and with left upper quadrant pain. First of all, I really want to emphasize on approaching the fever, and also I want to go ahead with the left upper quadrant pain. So whenever the fever, it's a natural response. Whenever the infection comes, when a bacteria or virus or exogenous pathogen comes, our immune system or all soldiers or army will attack, will try to act very smart, and they releases a lot of interleukins, and particularly interleukin 1 and the other molecules like TNF alpha, and with the products called prostaglandin E2, the product of arachidonic acid metabolism, and they're gonna act on the hypothalamus, which regulates the temperature, and that creates mismatch and throws a fever. And technically, definition of fever is anything greater than 38 degrees Celsius and greater than 100.4 Fahrenheit. So whenever you see fever, okay, we always think of infection as our preliminary thing. Let it be any kind of bacterial, because usually bacterial and viral infection usually present in acute manifestation, and parasitic and fungal infections and usually present chronically, except some situations like malaria where patients present in acute manifestations of fever pattern. So infection always goes in the top bucket list. Okay. Other than infection, what are the other causes which could cause a persistent fevers, which prolongs for days or to weeks, which is the classical symptom which is seen in this patient, where the patient has been having fevers for 2 weeks with the tachycardia in the range of 150s and 160s. And Keaton even mentioned that he did not see the level of tachycardia in his entire lifetime. So that much amount of tachycardia is going on. So what could be the other causes excluding infection? That is malignancy. Like more common liquid malignancy is much more as more propensity to cause fever than the solid organ solid tumors. And the other major bucket which falls under the category is autoimmune etiology, like patients with lupus and adult onset Still's disease, where we are emphasizing to our discussion on, and Skinner syndrome and vasculitis, polymyositis, dermatomyositis, and all the infectious bucket. And it also throws up a lot of persistent fevers along with other constitutional symptoms like weight loss, as Ohan was emphasizing on. And the other bucket falls is drug induced, like neuroleptomalignant syndrome. Let's say the patient is on any antipsychotic medication, they're gonna have the muscle rigidity, other autonomic symptoms. And the Steven Johnson syndrome, which involve less than 10% of body surface area, and toxic epidermolysis and necrolysis, which are most commonly seen with drug induced and also causes fever. And drug-induced hypersensitivity reaction, also called a DRESS syndrome, can also throw up this kind of fever. And lastly, the endocrine abnormality, like any patients with hyperthyroidism or patient with thyroid storm could also present with fever. So whenever we are approaching the fever, so these are the important bucket list, but the top most important, which is a pretty reversible thing, is to do with infection. So whenever it's better to focus first on infectious workup, and then if it is positive, we can shoot identify the right bug with the right agent to shed off the infection. So this is the approach. And the next concerning thing in this patient was left upper quadrant pain. Whenever we approach abdominal pain except the hypomnemonic, we always think of anatomical approach. Let's say the patient has right upper quadrant pain. We always think of liver, gallbladder, somewhat to pancreas, right? And the same way, what is the major organ which is sitting, under the ribs in the left lower quadrant? It is spleen, right? So, and also it is, the spleen and also it has attachments to the kind of, the diaphragm. It also has, the patient has some kind of pleuritic pattern. We are not sure whether it's something related to the lung pathology or abdominal pathology. And I want to emphasize on splenomegaly in this patient. And also subsequent workup showed in this patient, the CAT scan of the abdomen and pelvis showed steatosis because of this BMI, and also hepatosplenomegaly, and with small retroperitoneal lymph nodes. Okay, now how I'm going to deal with splenomegaly, which is based on physical exam or any kind of imaging. And Ravi, recently we had an academy session that, if you're thinking of any cirrhosis, because whenever we think of splenomegaly, we always, it's like a quick reflex, like, okay, that might be cirrhosis, like kind of decompensated liver disease with associated ascites, varices, and splenomegaly, all this kind of correlated symptoms. That constitutes water, right? Because it's the pressure buildup, and there'll be splenomegaly and sequestration and all that, manifestations. Now, the question is, what are the except the water, what are the other conditions which could, give rise to this kind of splenomegaly? And now again, it's better to have a systematic approach, and we have a great CP solver schema on this. Again, first of all, look for the infections, as I mentioned. Are there any viral agents like HIV, CMV, EBV? All these kind of agents, viral agents, will cause some kind of prodromal manifestations and gives us a splenomegaly. Are there any tick-borne infections like ehrlichiosis or rickettsiosis, or granulomatosis, like even with TB, pulmonary TB, which disseminates like miliary tuberculosis, or histoplasmosis, which has a characteristic dissemination to entire reticulothelial systems, and leishmaniasis, and especially visceral leishmaniasis. And that goes to the infection bucket. And what about the malignancy, like even with leukemias and lymphomas, where they have extramedullary hematopoiesis, and then once the bone marrow is getting destroyed, now liver and spleen takes up the role, and it produces a lot of blood cells, something like that. And then also gives us a splenomegaly. And what about the other autoimmune conditions? And we have a great 3S mnemonic, these systemic SLE lupus and Still's disease and sarcoidosis. Remember 3S for autoimmune bucket of splenomegaly. And again, the drug-induced hypersensitivity reaction or DRESS syndrome, along with eosinophilia, they're going to have splenomegaly. And except this part, the malaria and babesia can also cause splenomegaly. And in the RBC, in the the bucket, patient with sickle cell disease initially have spleen sequestration, and they'll follow with autosplenectomy, and thalassemias, and hereditary spherocytosis, they're going to have splenomegaly. And lastly, molecules like amyloidosis, where they're going to, the kind of protein which is going to deposit on the extracellular interstitial space, and they're going to cause not only splenomegaly, it can cause enlargement of all organs. So now, our patient has persistent fevers. Now we understood it could be infection, inflammation, endocrine issues, or drug induced. Unfortunately, the patient is not taking any of the medications. Now we are stuck between most commonly infection versus inflammation versus malignancy. And also, and his age was 30-year-old. And now with this history, how I'm going to make the progress, how I'm going to take the next step. In that scenario, Rabi has, clearly demonstrated the utilization of CBC, complete blood picture. Let's say, if the patient has any kind of acute bacterial infection, like bacteremia, like endocarditis. Now, obviously, if you look at this, the white count, you're going to have a lot of, neutrophils, right? Along with, if you do the transthoracic echo, you're going to see endocarditis, all the kind of vegetations which are going to stick on the valves. At the same time, you can take a lot of history, whether he's having any IV drug abuse, any kind of, dialysis catheter, and all these things really helps you. Okay, now the patient has splenomegaly and the infection with polymorph, with the neutrophils, I can think of endocarditis. But there is other bucket of autoimmune etiology, especially stills. The patient has neutrophilia. Neutrophilia, the presence of more of neutrophils greater than 70 to 80%, without having any infection. So I would call it as a sterile hyperinflammation. There is a lot of fire of inflammation going on, but no infection. So whenever there is no infection, which could be proved on blood cultures, urine cultures, or any kind of the serologies, HIVs, and everything. But if still you're seeing the neutrophilia with presence of the persistent fever, always keep Still's disease in your other differential diagnosis in addition to infection workup. Let's say, apart from with splenomegaly, if you're seeing some kind of eosinophils, you can always think of drug-induced hypersensitivity reaction, right? If I'm seeing a lot of lymphocytes, I can think of mononuclear-like reaction or lymphoma. So the CBC, when I'm, whenever, when I'm seeing the patient, now I'm going to look at the CBC. So that based on CBC, I'm going to make the next steps. Okay, whether this patient has kind of infection or inflammation or any kind of malignancy, and based on that schema, I'm going to make the further workup to identify the exact etiology, what is causing fever in this patient. Okay, now coming back to our patient, he has been having, this splenomegaly, which was proved on, imaging, and moreover, he has throwing up fevers of 102, 103, persistent tachycardias in the range of 150s, 160s, and then his other exam was unremarkable, except he has some kind of ulcers in the mouth. Other than that, it was unremarkable. But CBC, as I mentioned, this patient has neutrophilia. And because of this, all this kind of infection, the manifestations, probably we are missing any kind of infection. So the team has actually started with vancomycin and zosyn empirically to mitigate any kind of infection. But what happened was, blood cultures, urine cultures, and the team has ordered all the $1 million workup for infection, but all the infections came to be negative except one infection, which I'm going to talk about later. And now that rules out, now the patient is not responding to the antibiotics. Still he has been having fever. It means I did not identify the exact etiological agent, so that is the reason, that is what I'm lacking. Now, what could be the other manifestations? And later, the patient developed, the history was complicated, and he was in the floor, and he transferred to the cardiac ICU because he had the persistent chest pain, and he got a cardiac MRI which showed the myopericarditis like pattern on cardiac MRI. And he was started on other empirical management for NSAIDs, aspirin, and colchicine for pericarditis. Then later, the team has ordered one investigation, and apart from with the clinical history, they found to be the diagnosis as the preliminary diagnosis as adult onset Still's disease. So today I'm gonna walk you through some of the nuances with adult onset Still's disease. So what is Still's disease? It's a rare multisystemic inflammatory disorder. As you see in our patient, he has sore throat, he has throbbing headaches, he has left upper quadrant pain, and also he has complicated by pericarditis. And if you look at the number of organs involving, and with a lot of raised inflammatory markers in these like ESR, CRP, neutrophilia, it's a rare multisystemic inflammatory disorder. So what are the demographics where people will be affected? It's most likely young to middle-aged population. All right, let's say if the exact scenario happens in 80-year-old man, am I really going to think about Still's disease? Rarely, very unlikely. I'm going to put other workup like malignancy in my topmost differential than Still's disease. Now, you may wonder, okay, what is causing this kind of aggravating inflammatory disorder? The etiology is not clear mentioned, but one proposed theory was viral etiology, where the lot of starting from mycoplasma, Coxsackie, adenovirus, and all these things will create a fire, and then the post-infectious and the all inflammation will take over, and this create this kind of inflammation fire, result in this manifestations. And do I have all strong evidence to diagnose this disease? Not really, unfortunately, no. So that is the reason why it's called as diagnosis of exclusion. I'm going to rule out all possible infections. I'm going to rule out all possible autoimmune etiologies, malignancies, drug-induced, reversible causes, endocrine causes, and then I'm going to stick on to adult onset Still disease. Now, but fortunately, we have some criteria. There are a lot of criteria across the worldwide, but we frequently use Yamagushi's criteria to diagnose adult onset Still's disease. Diagnosis usually require at least two major criteria. What are the major criteria? Fever greater than 39 degrees Celsius for more than 1 week. The pattern of fever in the situation in the literature also mentioned that it's called as Cotodian fever. I'm just curious. I just want to, ask any of the participants, do you know what exactly is Cotodian fever? Could anyone wants to comment on it? I just want to hear your thoughts. If you have, if you know anything about it. Exactly. So the daily fever spikes. Exactly. That's amazing. The daily fever spikes is a situation where it peaks up to 102 or 103 and reaches the baseline. And the fever usually occurs at the same time. So the pattern of fever called Cotodian fever. And the other characteristic criteria is evanescent rash. I don't know whether I'm pronouncing it right. And you know what evanescent rash is? It's like a fleeting rash. When the fever spikes goes up, the rash also goes up, and the fever goes down, rash also progressively goes down. It's a pretty reversible thing, but patients usually have associated dermatographism, like which is usually in urticaria or any kind of Cobner's phenomena, kind of new lesions developing, or kind of pruritus, a lot of pruritus, and arthralgia. But because all this inflammation is creating fire of lot of joint pains. And as I said, leukocytosis, particularly neutrophilia of greater than 80%, but without any infection. And what are the minor criteria? There is elevated ESR, elevated CRP, and the team has ordered, the Keaton has, ordered an, ferritin level that was, elevating, that was increasing progressively. It was set 10,000, 12,000, 15,000, which gave them strong evidence to say it's possible Still's disease. And sore throat, lymphadenopathy the patient has, on the CAT scan of the abdominal pelvis showed retroperitoneal lymph nodes, and he has also splenomegaly and abnormal LFTs. I forgot to mention that the patient also has, ASTs and mild ASTs and ALT elevation, and has negative RA and anti-nuclear and NA anti-nuclear antibodies. So the thing here is, if you fit this kind of criteria, then if you go back retrospectively and think, okay, am I going to my patient is going to fit all this criteria exactly, and that really prompted the team to diagnose it as adult onset Still's disease. Then you may be wondering what could be the cause, because initially before he presented to the ED, he went to the primary care and he has some kind of flu-like symptoms. He got some, oseltamivir or other prophylactic medications, but the Keaton has also ordered mycoplasma titers that came to be positive. So in this situation, as I mentioned, though etiology is not clear, the viral etiology like mycoplasma it started creating the fire, and then immune system is going to take over and creating a lot of hyperinflammation. Yeah, so this is the criteria we follow. And I just want to emphasize what are the other conditions where you're going to see lot of ferritin levels. So one thing is Still's disease. One is the catastrophic antiphospholipid and CAPS, catastrophic antiphospholipid antibody syndrome, PJP, pneumocystis jirovecii pneumonia, and histoplasmosis. So these are some of the causes of hyperferritinemia. And I'm so sorry. And what are the complications? Like, as I mentioned, arthritis or arthralgia, right? If I leave this patient, not rating this patient, if I do the serial X-rays of this wrist bone, is going to develop ankylosis. All bones are going to get fused because of the, they're going to fibrosis, the kind of, they're getting close together. It's called ankylosis. And also, one of the possible complication is macrophage activation syndrome, also called as HLH. The interesting thing about the small nuance between HLH versus Still's disease is, as inflammation progresses, then suddenly the bone marrow stops producing all the blood cells, and you're going, instead of neutrophilia, you're going to see pancytopenia, anemia, thrombocytopenia, leukopenia, and markedly raised liver enzymes in the range of thousands, as you see in drug-induced liver injury cases or ischemic hepatitis. And ferritin goes to the range of 45,000, and there will be hypertriglyceridemia levels, and a hypofibrinogenemia, and all this kind of, and there is a ASH as 2004 ASH, the calculator for HLH, and you can put all the scores and it will give you the clinical, the stronger, the supportive diagnosis of HLH. And as far as the treatment wise, this patient initially got hydrosteroids and with empirical NSAIDs, and he was and further management, he got anakinra interleukin 1 inhibitor. So this is a small, rough overview of adult onset diseases. If you want me to summarize all the information, I would always say, this case was really interesting and really taught me a lot of, things which I really don't know before. One thing is, if the patient is coming off fever, always think of infection, but it's always good to have other inflammatory etiologies like HLH, Still's disease in your differential diagnosis so that you won't miss it in the first go. And also ordering a ferritin level. I really don't know how much it will really help us in supporting our diagnosis, but it's always good to have in our back pocket. And yeah, that's all I have. Thank you so much for your attention and patience. Let me know if you have any questions.
Rahul, it was amazing. It was so good. It was really amazing. It was a really tough case to diagnose and to discuss, and you really summarized it super beautifully and really well. You really highlight branching point amazingly, and you explained the splenomegaly, still disease criteria. Really, it was informative and educational. I really enjoyed it really well, and I think all the people here agree with me. You could check the chat. If anyone has any question, please feel free to put it in the chat.
I think Mukund has one question. Let me read this question. Do patients completely difference between fever state? As per, I was going through the evidence, Mukund, they said that it usually goes to the baseline. That's what the literature is. Again, I'll get back to your question once I have a stronger evidence to say that. But it usually goes to the baseline, even with fever and the rash. Exactly. So the cause of this patient is, yeah, the underlying trigger, the baseline trigger is mycoplasma, and then subsequently all these things have happened. Yeah. Any questions, guys?
Okay, I think then if nobody has any question, that's it. Thank you, Johan. Thank you, E. Thank you, Rahul. It was really great educational session. And thank you for everyone who has joined us. We hope to see you tomorrow. Bye.